Hi, my name is Stephanie Hertz, Marketing Director at Warwick Forest. Warwick Forest is proud to be the premier sponsor of CNU's Lifelong Learning Society, and we welcome you to the Riverside Lecture Series. Today, I have the pleasure of introducing Jennifer Campbell-Raab. Jennifer is a registered nurse currently serving as a Behavioral Health Education Coordinator for Riverside Health System. In her role, she works to improve the overall patient experience by providing quality mental health and substance abuse disorder education to team members involved in various aspects of care across Riverside. Jennifer also works to support the community by connecting individuals, groups, and organizations with resources to promote positive mental health and well-being. She is passionate about helping to destigmatize mental illness, and she values trauma-informed care as well as timely and effective crisis intervention. Behavioral health nursing is a second career for Jennifer, who previously worked as a television newscast producer. She holds a Bachelor of Science degree in nursing from Old Dominion University and a Bachelor of Arts degree in both psychology and philosophy from Clemson University. Please welcome Jennifer Campbell-Raab as she speaks about the changing landscape of mental health treatment.
Everyone, hope you're all doing well today. Happy Friday, the weekend's almost here. So as Stephanie said, my name is Jennifer. I'm a nurse and my passion is mental health. So I'm really excited to get to meet with you today and learn together and talk with you all because there's a lot of stuff going on this month and next related to mental health and substance use disorders. Just a quick show of hands. Anyone here have a history of working in mental health? Okay, so you two have a job, or three. You'll have a job. You have to keep me accountable. I did my best today. What I really wanted to do was take a look back at where we used to be a long time ago in mental health treatment and, journey us up all the way to now and look ahead. So hold me accountable, did my best to get the progress right, but there's a lot that's happened. So we're going to talk about those early approaches to mental health. We're going to go pretty far back in time, a few centuries before any of us were born. We'll also talk about those progressive changes in mental health that I mentioned. Early pioneers, or as they would call them these days, influencers. All right, and we're going to look at current treatments. We're going to look at continuing challenges because we haven't figured everything out yet, right? And there's always something new that we need to tackle. And we're going to look at crisis response, which is so important these days. We'll see what's on the horizon, as I mentioned, and we'll talk about your role. So what can you do? How can you show your support and get involved for those and be able to help those in need? And then at the end of the lecture, we'll finish off with a few tips about maintaining the health of your brain and the health of your mind. So let's get started. We're turning back the clock several centuries, looking at early approaches to mental health. And we're going to start way back in the era of the Middle Ages and slightly beyond to the 17th century. So in the Middle Ages, those were also known as the Dark Ages. It was a period of what was considered decline after the fall of the Western Roman Empire. And at that time, mental illness was not understood at all. So what we had at that time were individuals who had mental illness, but they were considered to be, instead of unhealthy, bewitched or cursed, maybe even possessed by demons. So the treatments were, of course, not therapeutic, unfortunately. They were actually pretty brutal. So those who were afflicted were often, they faced executions. Some of them were burned at the stake. They were treated as witches. Those who survived and didn't face that were imprisoned in dungeons. At least they were able to live, but they didn't really have a quality of life. And of course, their illnesses were not being addressed at that time. So there wasn't that much hope in that era. So here on the screen, I wanted you guys to look at this picture. I found it pretty interesting. This painting is from that time frame, and it shows a practice that's called trepanning or triphoning. Any guesses as to what's going on here? Close. They are being pretty invasive in the head there. But instead of lobotomies, which of course they went into and did some other things to your brain where they disconnected some portions of it. This one doesn't go quite as far as the brain right now. In this picture, what they're depicting is chipping a hole in the skull of someone to release evil spirits, because again, that was thought to be the cause of mental illness. So trephining, triphoning, chipping a small hole to release those evil spirits. So do you think that was effective? No. You know, I wondered that. The question for those of you who are joining us virtually was, what's the point of the book on the head? I also wondered what was the point of the funnel on the head. And I honestly don't know, except for maybe the artist himself was trying to share that maybe he didn't think it was a very valid practice. But it makes for something interesting to kind of illustrate what we're talking about back in history. It wasn't effective. It was often fatal. The process would often lead to infections. So no, it wasn't a good practice. So let's move ahead into the 18th century. That's where we start to see a turn from imprisonment to hospitalization. That, you know, of course, in Western civilization, this is the area I'm focusing on here. But unfortunately, the use of chains continued. So it was really just an environmental change. There wasn't much of a change in the ways of health treatment. The mentally ill were still ostracized. They were called lunatics. They lived in lunatic asylums. Those places were also called madhouses. They were staffed by untrained workers. So they didn't get proper care there. Around that time, the first asylum for the insane, using that terminology from that era, was established in nearby Williamsburg. And that was established under British colonial rule. And it was called the Public Hospital. It was 1773 when it opened. Care there was completely devoted to treating mental illness. The facility was also known as Eastern Lunatic Asylum, and now we know it as what you see on your screen there, Eastern State Hospital. So it is still up and running, providing care for about 300 patients. But I think it's pretty interesting that the first hospital devoted just for the mentally ill was right in nearby Williamsburg. All right, so let's look at another depiction of treatment in the area. This is also the 18th century. We did start to see some more changes around that time. This painting, it depicts French physician Philip Pinel removing the chains and shackles from patients who were held at a lunatic asylum in Paris. And this was alleged to have happened around 1795. So Pinel was a little more forward thinking at that time. He proposed talking to patients. Let's get them out of the shackles. Let's have conversations with them. Let's talk to them. Let's put them in sunny, well-lit rooms. Let's get them exercise out on the grounds. So now, you know, we're starting to get somewhere. Moving into the 19th century. I love these pictures here. Charles Darwin's grandfather, Aramis Darwin, believed that rotational therapy, so spinning patients around, would improve circulation to the mentally ill brain. He thought it would lower what he called brain congestion and help treat mania. So a colleague, Dr. Joseph Cox, developed a technique for this, and you can see the picture on your left is the rotational chair, and it did become pretty popular for a while. It may look a little odd, but they may have been onto something, because when we get to the end of the lecture, we're going to circle back around to how important aerobic exercise and blood flow in your brain is to your overall health and your mental health. Around the same time, Benjamin Rush, who was a physician and one of the signers of the Declaration of Independence, he invented the other chair that you see here on the screen. It was called the tranquilizing chair. So the purpose of this chair was to control the blood flow toward the brain and reduce the force of the pulse in the head. So kind of different approaches, but also very similar. And of course, these have gone by the wayside. So in the 19th century, we started to see a shift in about the mid 1800s. We saw the emergence of psychiatry, what we now know as psychiatry. Additionally, we had the first medical mental health specialty organization in our country. It had quite a long title. I'm going to try to say it correctly. Association of Medical Superintendents of American Institutes for the Insane. So it's quite a long title. This organization has evolved into what we now know as the American Psychiatric Association. So I think we've probably all heard of that. So this pre-APA group, they started the first American Journal of Insanity. So you can see some pictures up on your screen here from that organization, some of the works they produced. This American Journal of Insanity later became the American Journal of Psychiatry. So it's interesting how changing one word can really change how we perceive something and how we interpret. It changes our focus. So yes, Journal of Insanity becomes the Journal of Psychiatry. Of course, there's other words here on the screen that also needed to change, lunatic and asylum being a couple of those. So we're still in the 19th century. And during this period, we started to see the rise of individual advocates for mental health, activists who were not physicians like Pinnell, who I just talked about, but just average citizens. So this is a picture of Dorothea Dix. She was a teacher from Maine, and she became aware of, there were some places in our country where the mentally ill were being jailed right alongside common criminals. She was upset about that. She started lobbying for change. Her actions led to the building of several mental health institutions across our country. Today, there's still a Dorothea Dix Psychiatric Center in Bangor, Maine, but the facility that carried her name that you might have heard of closer to us in the Tar Heel State, Raleigh, North Carolina, that has since closed. But that was the state's first psychiatric facility there. Unfortunately, with the best intentions, these institutions that were built based on her activism eventually became overcrowded, and conditions were not always fantastic for the patients there. So now we turn to Nellie Bly. That was her writing name. She was a journalist. She went undercover. She was from Pennsylvania. She went undercover as a patient and got herself committed to an asylum in New York City. The asylum was rumored to have horrific treatments of the patients there, horrific conditions, terrible treatment of the patients. So she went undercover and got herself committed to see if it was true. And unfortunately, the rumors were valid. So she experienced a little bit of what the patients were experiencing themselves, and she witnessed a lot. She was taken out of the facility after 10 days, and she wrote a book called 10 Days in a Madhouse. Anyone read that before? I do recommend it. It's a very interesting read. It's very eye-opening. So Dorothea Dix, Nellie Bly, they were leaders, they were advocates, activists. Their actions and others led to a lot of reform. In the 19th century, more changes. The need for formal training was recognized. So you have a picture on your screen of McLean Asylum, that's in Massachusetts. And this was the first training school for nurses in a psychiatric setting. I'm a nurse, so I really wanted to kind of focus the journey of nursing alongside the journey of medicine throughout this lecture. So it's not a school of nursing, but they were formally given some training about how to care for the mentally ill within a psychiatric facility. So that was a good step forward. I think everyone's heard of Sigmund Freud, the founder of psychoanalysis. We're at the very end of the 19th century now. In 1896, this Austrian, neurologist coined the term psychoanalysis. He had done some work with a colleague named Charcot on hypnosis, and he also worked with a colleague named Brewer on patient interviewing. And his work with them kind of compelled him to shift his focus away from neurons and brain tissue to what he was calling the mind. So he began to believe that mental illness might not always be related to what's going on physically in the brain, but with your mental state. So he started really changing the focus of how mental illness was looked at. He talked about conflicts in the psyche. He talked about how they could be treated by dialogue through a patient and a psychoanalyst. So that was very groundbreaking. So moving into the 20th century, a former mental health patient, this man that you see on the screen, his name is Clifford Beers. He wrote a book after he was hospitalized at a Connecticut institute, and he was dehumanized. The treatment was just dehumanizing there, and he came out very upset about mental health care in America. And he wrote this book, A Mind That Found Itself. His work was really set ripples. It started with the book, but a year later, he founded the National Committee for Mental Hygiene. And that later became the National Mental Health Association, which you probably heard of. In 1950, that's when that name was changed. And then in 2006, it was changed to Mental Health America. So it's his organization that's evolved and through all these years. He really laid the work for groups as advocacy. So instead of individual activists across the country, he started getting people together and forming groups and saying, what can we do together to change mental health? He focused on improving standards of care. So that's when we start seeing that across our nation. And today his legacy still lives on. There's a center that bears his name in New Haven, Connecticut. So getting back to the education, in the early 1900s, around 1913, the first formal psychiatric nursing education program was organized, and that was at Johns Hopkins University. So remember, we had the training in a hospital setting, but this really brought education to a university environment. Around the same time, around 34, the American Board of Psychiatry and Neurology was founded. And the purpose of that board was to help identify specialists in psychiatry and neurology through board certification. So they're raising the standards for care. And another significant development in the first half of the 20th century, 1946, U.S. President Harry Truman signed an act to establish the National Institute of Mental Health, which still exists today. And the purpose of it was to conduct research on mental illness and treatment. Formal research, which we know is key to evidence-based treatment, which we turn to today. So we're going to move into the 1950s and beyond in this century. That's when we started seeing the process of deinstitutionalization. So we started seeing a move toward community-based care. The emergence of specialty medicine happened around that time. So although they had different names, we started to see the use of a few types of medicines that we would now call antidepressants, antipsychotics, and mood stabilizers. The Diagnostic and Statistical Manual of Mental Disorders was published in 1952. So this was the first official clinical manual of mental disorders. And the use of the term reaction was proliferant throughout the book. And that really reflected the current thinking that mental illness was a reaction to factors, social, psychosocial, biological. It was really a change in the way of thinking. So that was the first edition. Any guesses about the version that we're using now? Not quite that high yet. So we're on the DSM-5 right now. It's the 5th edition, TR, the text revision version. So it's gone through several changes over the past, let's see, from around the time that was published in the 50s, 52 to now. And also around that time, they started recognizing the value of pharmacological treatment, so the medications, plus cognitive therapy, which is, of course, a model we follow today. We strongly believe that medications are helpful, but therapy is also needed. So that was a big shift in thinking at that time. This was also around the time when Hildegard Peplau published her theory of interpersonal relations. That was in 1952. So 2 years later, after publishing this, she helped establish the first psychiatric nursing graduate program. So we had the undergraduate at Johns Hopkins, and she helped establish the first psychiatric nursing graduate program that was at Rutgers in New Jersey. All right. So from there, things moved really quickly in psychiatric mental health nursing. I put a lot of dates up on the screen that you guys can take a look at on this timeline. It marks a lot of milestones. We have the first publishing of psychiatric mental health nursing journals, standards of practice for psychiatric mental health nurses, specialty certifications. As I said, things moved pretty quickly between 1963 and 2000. So that's taking a broad look. We started around the world and then came down and looked at what was happening across the nation. But what was happening here on the peninsula in that time frame? This is Dr. Wendell Pyle. In 1960, he founded Bayberry Psychiatric Hospital in Phoebus. Have you guys anyone heard of Bayberry? Okay. All right. In 1978, it was renamed the Peninsula Psychiatric Hospital. And in 1983, the hospital moved to its current location, which is on Executive Drive in Hampton. In 2000, Riverside Health System purchased it, and this year, what we've known for a while as Riverside Behavioral Health Center got a new name. And I don't know if you've heard that yet. It's brand new. Riverside Mental Health and Recovery Center. So the name change was really meant to focus on recovery from mental illness and substance use disorders. All right. So currently, RMHRC, as I'm still getting used to saying, I've been used to saying RBHC for a long time. Currently houses 90 inpatient beds. There's even a courtroom on site for commitment hearings. It is an exceptional facility. I'm a little biased. I've been working there for the better half of a decade. So it has a big place in my heart. I'm really proud of the work that's being done there. RMHRC also offers day treatment programs for substance use disorders. And soon they're going to offer day treatment for mental health disorders as well. And what you're looking at here in the bottom screen is a rendering of our what's going to be the first freestanding psychiatric emergency department in the state of Virginia. So that is going to be opening very soon, and we're very excited to be kind of paving a path for that. We know that it's much needed. We know that especially since COVID, there's been kind of an explosion in the number of people needing mental health treatment. And often, I'm sorry. Oh, I'm sorry. It is actually on the same campus. It's right there adjacent to the building. They're attached. Yeah, so the question for those who are online, the first one was, where is it? Which I answered. And the second one was, will it be for all ages? Yes, it will. We do have inpatient treatment for adults and adolescents, but it's an emergency department. So we know that we may have children who are younger than 12 who come there for need. So yes, it will serve all ages. It does have different treatment areas so that parents who bring their children there for services will have a separate treatment area than the adults. And of course, it's designed with the latest in safety features. And the good news about the psychiatric department is that coming there, instead of going to a medical ED, those who need treatment are going to get that specialty care right away instead of waiting in the overcrowded medical emergency rooms for days. So they're going to get that specialty treatment right away, and our goal will be to help stabilize them and even get them some therapy in the ED if needed, if they're in there for that long. All right, so those were great questions, and I showed a picture of Dr. Pyle. So of course, I want to also show you our medical leaders who are at the helm right now. We have Dr. Ryan McQueen in the middle there. He's our Chief of Behavioral Health and our Medical Director of Adolescent Services. And at the bottom is Dr. Campbell-Raab, and he's our Medical Director of Adult Services. So we're grateful for what Wendell Pyle started, and we're honored to be carrying on that work. Yes. That's a great question, and I will circle back around to that one at the end if we have time. The question was about interacting with the Community Services Board. In brief, we've already had the ability to have patients walk in for evaluations for years, and we often have Community Service Board representatives come in and do their evaluations on site. So I'm sure it'll be similar, but I'm not sure exactly how it's going to look. All right, so that's a quick history. With all those changes evolving over the century and the needs of those with mental health challenges changing, our shifting perceptions of mental health, where are we right now? So how many Americans are experiencing mental illness right now? So I want to do a show of hands. How many of you would guess it's as few as 1 out of every 50? Maybe? About 1 out of every 25 Americans. Do I need to go lower? 1 out of 10? So it's actually 1 out of every 5. So 1 out of every 5 U.S. adults experiences a mental illness each year, and 1 out of 20 experiences a serious mental illness. Looking at our youth, 1 in 6 between the ages of 6 and 17 experience a mental health disorder each year. So with a serious mental illness, I would assume there's a diagnosis for sure there. With experiencing symptoms of a mental illness, it could be a short-lived crisis, maybe the first presentation of symptoms. So yeah, I think there's some mixed different presentations in there. So we have some questions in the room about diagnoses, formal diagnoses versus family members that you might question their mental health. Again, I would say that with the 1 in 20, that's somebody with a formal diagnosis. And with the 1 in 5, I would say that's somebody who's maybe sought help for the first time and doesn't have a mental illness to the extent that they require hospitalization. That would be my guess, but I can send you my source for these numbers. I believe this all came from NAMI. I've got my references at the end, but we're going to talk a little about NAMI as well. So I'll be happy to send that to you. And then that last fact there, it's a very dismal fact that suicide is the second leading cause of death among those aged 10 to 14. It's hard to think of a 10-year-old being in such crisis that they might turn to this, but unfortunately, that has happened. So that's why treatment's important, right? These are some of the most common diagnoses these days. We have categories of anxiety disorders, generalized anxiety disorders, panic attacks, phobias. We have depressive disorders, different types of those too. Major depressive disorder you might have heard of, seasonal affective disorder. There's perinatal depressive disorders, bipolar disorder, post-traumatic stress disorder, which we often call PTSD, schizoaffective disorder, and schizophrenia. So we have a combination here of mood disorders, some thought disorders, and so forth, and some even being psychotic, which is simply defined as losing touch with reality. That's what we would call psychosis. So these are some common risks that come with these diagnoses: suicide, self-harm, harm to others, and substance use disorders. You may find it interesting to hear that about 15% of older adults are living with depression, but half do not get care, even though it is treatable. Depression can be overlooked in older adults because it may be viewed as a symptom or mistaken of what some folks might consider normal aging. For example, low energy or fatigue, that could actually be signs of depression. Trouble with memory could also be signs of depression because it's believed that when you're depressed, your brain may have trouble filing information away properly. So care should be sought anytime there's concerns. Today in mental health, we have what we consider a spectrum of wellness with mental health and mental illness on opposite ends of that spectrum. At the healthy point, we have those who are generally emotionally well balanced. They're stable, they're goal oriented. In the middle, that's more at the problem point. Those are showing some distress, the inability to cope, but they're still able to function on the day-to-day and carry out the activities they need to do. At the disorder point on the opposite end, there's people who are unable to cope with stress. They exhibit significant changes in their behaviors, their thoughts, their emotions. So care today is individualized and evidence-based. We look at what the research shows us. We know that there's no single plan of treatment that's going to treat everyone. It's not universal, so we individualize care. It's not experimental anymore in the sense of some of the things that we saw in the past. There's still things that are being trialed. Of course, we'll talk about a couple of those. And today, terms are chosen carefully. So we have person-centered language. So for example, referring to someone as an individual with a substance use disorder is a much more neutral, kind way of saying someone's a drunk, someone's an alcoholic, someone's an addict. So person-centered language is very important. It really puts the focus away. We don't want to refer to someone as their diagnosis. It puts the emphasis on the person. They're struggling and their symptoms need to be treated in order to get better. Training in mental health professions often encourages the development of an understanding of the patient's perspective or point of view. So when we talked earlier about asylums, which is what they were called back then, being staffed with untrained individuals, the training these days really focuses on trying to understand the patient perspective and what it must feel like from the patient's point of view. We also have an emphasis on trauma-informed care because the last thing any of us want to do is inadvertently re-traumatize any of our patients. So it's safe to assume that anyone could have a history of trauma because unfortunately due to the stigma related to mental health, not everyone discloses that they have had a history of trauma. So as mental health needs increase across our population and within the young, we're seeing a prompt response. I've talked about what Riverside's doing, but it's not just about Riverside, right? There's a lot of great, fantastic healthcare organizations addressing these needs. Right across the water in Norfolk at CHKD's Children's Pavilion, they've expanded their treatment. It's very comprehensive. They have, of course, the inpatient treatment for children who need mental health treatment. They also have day programs at CHKD. They provide follow-up care. They have prevention programs, and they do a lot of important research there. Their physicians are doing a lot of great work with what's called VMAP, that's the Virginia Mental Health Access Program. This is a statewide initiative, and it helps primary care providers who are starting to become more and more overburdened with patients coming to them with mental health issues that they might not have experience treating, but of course, due to care, they're trying to treat. This VMAP program provides primary care physicians and providers a chance to get more education on the medications they might need to prescribe, on treatment modalities. It also provides vital connections. It provides actually a way for them to like phone a friend, reach out, call another provider. They have a consultation line. So you do have to register to be part of this program, but it's really innovative and I think it's much needed. And I think they're doing really great work to try to help keep up with the needs that are growing. So let's take a look at what's on the horizon. Anyone worn one of these before? Tried that out? Yeah, I've tried it out too. Virtual reality is very interesting. And so they're exploring how it could be used to treat mental health. And they've already had some success with patients who are very socially anxious. They've benefited from VR treatment where they're submerged into worlds where they get the chance to practice communication skills. So they've had some success with that already. They've also had some success in treating individuals with phobia using VR. They are also using VR right now, kind of trying it out with those who have served in the military and suffer PTSD, so that post-traumatic stress disorder. They can actually tailor combat scenarios to be very unique to what that individual experienced on the front lines and is relevant to their trauma. And they can help them develop appropriate coping mechanisms. And many VA hospitals are starting to trial this. So there are also hundreds of mental health apps available in Apple and Android stores. However, this new technology, comes with a little uncertainty. There are no review boards, no national standards for evaluating the effectiveness of these apps. There's no peer-reviewed research to support their claims. I would be personally, a little cautious about sharing any confidential information with any app on a phone, but they must be working because a lot of people are using them. They're becoming very, very popular as a way of maybe getting some initial help. So also on the horizon, we have a couple of different fancy things, transcranial direct current stimulation. So that's not yet FDA approved, but it's in trials. So far, it's shown some success with treating depression. It's non-invasive. It uses electrodes to deliver a low current to the scalp. They still need to do a lot more trials before they move forward with this and figure out who it might work for and who might benefit, the most from it. Along a very similar path is transcranial magnetic stimulation. So you might have heard of TMS because that has been around for a little bit. It's also non-invasive. It uses magnetic fields to stimulate nerve cells in the brain. It is considered safe. It's been cleared by the FDA, and just to throw that out there, does not mean that's been approved by the FDA. It has not yet been approved. By clearing it, they're saying they don't think it's going to do harm. By approving it, if they do approve it, they're saying they think it's going to be effective. So a little distinction there. Cleared, not approved. So this has been used to treat a range of conditions, including depression, which I just mentioned, also obsessive compulsive disorder, PTSD, which we've talked about, substance use disorders as well. You might have heard of light therapy. That is also FDA cleared, but not approved. And that they are marketing light therapy to help with seasonal affective disorder. There are lots of machines out there on the market already. But again, they're not regulated. They're not FDA approved, so there's no regulation for that. And they do have some risks. For instance, light therapy has been shown to trigger manic episodes in those with bipolar. So in other words, don't try this at home. When in doubt, always go with your physician's advice, right? But I just wanted to show you some things on the horizon. Largely due to COVID and the growing needs and needing to socially distance, we started seeing a turn towards teletherapy and telepsychiatry. And that's become very useful. Many health plans are now starting to cover it, and studies are starting to show that it can be as effective as in-person therapy and treatment. Most virtual visits just require you to have a phone or a computer. So it really is making strides in access to mental health care. All right. So getting back to medications, we talked about the introduction of medicines to treat psychiatric disorders. And now we have some advances. We have long-acting injectables that are starting to be used. They're the same medications that someone might take by mouth, but they last a lot longer. So, you might have a medication that's like a control release medication that lasts like maybe 24 hours or so, but these long-acting injectables could last weeks. They have a really slow release into the bloodstream. So that can really help with those who need psychiatric medicines, because it can help them stay stable outside of the hospital setting for much longer than they might be if they forget to take the oral medications that they're discharged with. So we're starting to see these used to treat psychosis and those with schizophrenia, and sometimes used as mood stabilizers for bipolar. There's also a number of support groups for mental health and wellness that are available and very helpful. Some are local in person, some are virtual. So again, it's that comfort level of the person reaching out. And we'll talk about one in particular in a few minutes. Despite all these changes, the challenges continue. Looking at the criminal justice system, for example, about 2 million times each year, people with serious mental illness are booked into jails. And about 2 in 5 people who are incarcerated have a history of mental illness. Among those with no place to call home in our country, the homeless, there is about 20% of those individuals who also have a serious mental health condition. And now I'm going to look at our crisis response. So a few years ago in 2020, then Virginia Governor Ralph Northam signed into law what's known as the Marcus Alert. Anyone heard of that? So the Marcus Alert was named for a Richmond teacher. He lost his life in a confrontation with police while he was experiencing a mental health crisis. And his sister did a lot of lobbying to get some changes going forward on the response to mental health, to individuals who experience mental health crisis. So this Marcus Alert was signed into effect, and it has several goals, but they include reducing the primary role. So trying to take the primary role away from police. We still need police to be safe, of course, but trying to take the primary role because they're not trained behavioral health professionals, right? So they have lots of training and lots of responsibilities, but the goal of the Marcus Alert is to try to shift it to someone who is by training, a behavioral health specialist, someone who's qualified. So along those lines, right here in Newport News, we have the Community Assistance Response or CARE program. So that's a collaboration between the Newport News Fire Department, the Police Department, and the Hampton Newport News Community Service Board, the CSB. And so members of that care team, they work together to provide initial support to those in crisis within the city. So when they are able to, that's how they respond with police, but also with the fire department who's had special training, and with a social worker from the Community Services Board. It's part of the goal to help try to decriminalize mental health and get the right help at the right time for the right person. So nationally, we have the 988 Suicide and Crisis Lifeline. That was formerly known as National Suicide Prevention Lifeline. It has a long 1-800 number that still works. But when you're in crisis, it's of course easier to remember 3 numbers like 911. So now we have 988, and that is specific for mental health crisis, and it's available across the country. That crisis lifeline is available 24 hours a day, 7 days a week. It is a national network of over 200 crisis centers across the country. It helps combine local care and resources with national standards and best practices. And anyone who is distressed and in crisis can just use their phone to either call or text or get on the internet on their phone and chat. So I think the texting is a pretty good advancement, especially for our younger generation that are not as accustomed as I was, always calling someone. So that's a great resource that we're seeing across our country and locally. So further efforts to equip as many people as possible with the skills to respond to someone who's in crisis include several trainings. One of them you see on your screen here, mental health first aid. This is a training that started out in Australia and was brought over to the United States. And to think of mental health first aid, think about CPR. Of course, in healthcare, we're all trained to do CPR, but there's also a push to get everyone outside, as many people outside of healthcare, trained in CPR as well, your basic CPR life-saving skills, so that if somebody's in a medical crisis experiencing a heart attack, hopefully there's someone who can jump in and perform some life-saving skills, right, to help them get stabilized and get to the hospital and get treatment as soon as possible. But what about mental crises? So that's where mental health first aid comes in. It is a certification course. It's an 8-hour course developed to help each of us identify, understand, and provide an initial response. So first aid, this is not treatment, not professional treatment, but this is just mental health first aid. So that initial response to someone in crisis. So far, the organization behind it, the National Council for Mental Wellbeing, says they have trained 3 million people across the US already, which is pretty big, including Michelle Obama. And their goal, of course, is to make it as common as CPR training. So let's look at your role. Your generation, the matriarchs and patriarchs of your families, you're in a powerful position to influence younger generations, your children, your grandchildren, to help reduce stigma with them. We've come a long way in reducing stigma, but we still have some work to do. If they hear you talking about it, they may feel more comfortable talking about it among themselves. There may even be a friend, a neighbor, someone from your church that you're concerned about. And by talking about it, you have the power to start the dialogue that could save a life. It is okay to talk about it. I encourage you to talk about it, to destigmatize substance use and mental health challenges, and encourage others to seek treatment. So I mentioned support groups and that we would come back around to those. And so right now I want to talk about the National Alliance on Mental Illness. We call it NAMI for short. NAMI tells us that when we start talking about it and breaking down this stigma, we open up new roads to recovery. NAMI is a robust organization. It is a well-known support group. They emphasize phrases like there should be no silence, no shame. I'm going to show you a video, introduce you to Vanessa Abrams. She's a mental health advocate with lived experience with depression, anxiety, PTSD, and attempted suicide. In this video, she shares how she learned it's okay to not be okay, and how she found hope in the NAMI community. So this is about an 8-minute long video, and she's going to talk about her experiences and how she's found support through that organization. And then when we come back from the video, we'll talk about the things that are going on this month and next. All right, so magically, this is going to work.
5 years ago, when my brother passed, I was going to attempt, but because I didn't, in the spirit, I am a woman of faith, said to me, if you do it, your son will do that same thing again. So I did not. I checked myself in the hospital, but I want to share that my faith and NAMI got me to sitting here in this seat today. My name is Vanessa Abrams, and I am a suicide survivor and sibling survivor. I am diagnosed with major depressive disorder, anxiety, complex bereavement disorder, and PTSD from my brother's death. My brother, my older brother, which is a U.S. Army decorated veteran, passed by way of completed suicide. My mental health journey began as a teenager, and I was diagnosed with depression, however, wasn't really treated as a teen for that. So what spilled over into my adulthood, where things really became tough, and suicidal ideations, and began to have to go on inpatient as an adult. And that is when really I was diagnosed with a major depressive disorder, where I began to learn more about what the stigma was, because I didn't know. My family, we didn't talk about mental health, nor did we talk about suicide. And then to fast forward, when my brother passed, my older brother passed, is when I really, really became an advocate, if you will, even in my 6 attempts, and that 6th time I should have passed away, but I thank God that I didn't. When my brother passed is when I really, really dug deep, because I knew then it was generational. It was just not something that he did. And then, being the youngest of 5, I learned that I had another sibling that had attempted several times. So these are things that I didn't know. So I began to do a research, beginning to learn about the history, about my generation, about my family, about my mother, about my father, about each sides of the family. My father is a recovering alcoholic of 30 years. And I asked my father after my brother passed, why did you drink so heavily? Well, things really bothered me. I said, so you were depressed? No, I wouldn't say that. I said, depression is when we medicate with the substance, the pain. I said, so that is actually what you were going through. He said, I never thought of it that way. And you were right. So it just tells me that many of us are so uneducated about the importance of mental health, because there is no health without mental health. And my father even said, like, wow, I just didn't know. So that led me to also believe that my family members, even to this day, still don't understand what mental health is and mental illness is. And I truly believe there's the stigma. There's that boundary of the stigma where we're ashamed, or we don't want anyone to know what we are going through, and which I've been there. I was the stigma at one time when I was early on my journey, but it was the straw that broke the camel's back when my brother passed, because I said, this is it. And something deeper has to come to the surface as relates to mental health. I say all of this to say that it is so important. It is so very important that we become educated. NAMI, the National Alliance of Mental Illness, I must say, this is an answered prayer for me. I found NAMI when coming home from the scene of my brother's suicide. So I looked up suicide. NAMI popped up. Never heard of NAMI. So I contacted NAMI. I was invited to come in for classes, and I really was expecting more of a hands-off, but they were more hands-on. And not only that, they held my hand until I was comfortable. I got personal coaching and mentoring as it relates to the programs and my journey from those that were more experienced on my journey of recovery. The power of NAMI support groups has been life-saving and life-giving to me. The programs that I am trained in is In Our Own Voice, where we learn how to share our pain, which is our story. Because I've learned and am learning that our pain positions us for purpose. I'm also well-versed in peer-to-peer, where it is such a powerful thing to be around peers that have experienced the same or similar things on their road of recovery. Also in several other groups, the connection groups, ending the silence, where you speak to students and letting them know that it's okay not to be okay, but yet at the same time, it is not okay not to get the help that you need. The NAMI walks are such a great way to break the stigma around mental health and mental illness. I walk for my brother, for every heartbeat that I still feel in my body, even though he's not here today, but in spirit. Every step that I take is for him. The NAMI walks for me are dedicated to people such as myself that have mental illness, that are on the road to recovery day to day and moment to moment. We may struggle, but yet we realize that we are not alone. And NAMI makes that a point. We are not alone. There is no health without mental health, and that we all have mental health. Therefore, we must take care of ourselves by doing the extra self-care, learning, also adding tools to our toolbox so that when we or if we get triggered, we are able to pull out the tools that we need to be on that road of recovery. NAMI has been like oxygen to my veins, and I just want people to know that there is no silence, no shame. With NAMI, know that you are not alone. I am right here with you.
I love her passion. And I appreciate you guys watching that with me. And I do want to point out that her sign that she held up, I think I had a typo in my presentation because I was saying that suicide is the second leading cause of death of 10 to 14, and her numbers were 10 to 34. Of course, 10 to 14 is included in that group, but more accurately 10 to 34. So I just wanted to correct that. We have a few more minutes. And we have a question? Mm-hmm. So how do people access the beds and how are they funded? That's a good question. Personal insurance pays for a lot. Medicaid, Medicare pays for a lot. And certainly at some places, including Riverside, those who don't have the ability to pay can come get treatment. So lots of different ways for that. Let's see. Just to be mindful of the time, because I know we're done at 12:15, I believe. I want to challenge you to show your support this month. September is National Recovery Month and National Suicide Prevention Month. World Suicide Prevention Day is just 2 days away on the 10th. And all next week, the 10th through the 16th, is National Suicide Prevention Awareness Week. So think about what you could do over the course of the next 22 days to help make a difference. One thing you could do, I encourage you to sign up this month if you feel inspired to join the Virginia Peninsula Out of the Darkness Community Walk on October 14th at Newport News Park. So that's a walk that's organized by the American Foundation for Suicide Prevention, and Riverside is a proud sponsor of that walk. Anyone here walked in that event before? It's pretty amazing event. It happens every year. Lots of people get out and walk and support. So, check it out and see what you think. October next month is National Substance Abuse Prevention Month, and Red Ribbon Week is October 23rd through the 31st. So the theme of this annual Red Ribbon campaign this year is to be kind to your mind and live drug-free. So the Red Ribbon campaign is really focused on challenging us as a community to help educate youth and young children, encourage participation in drug prevention activities. So that's a really youth-focused organization. So I would like to show you why I feel this is more important than ever. So on your screen here, you have some things that when I first saw them, I was really surprised to see them myself. This is kind of what we're up against: marketing campaigns that use childlike messaging in their advertisements, and they are marketing products that have drugs in them, THC, edible products, stuff like that. And this is what our children, our grandchildren are up against. And it's important, I think, as adults that we educate ourselves to know what they're exposed to, because we can't help them if we don't know what they're seeing. So I thought I would share this to you. Those bags at the top, the pictures at the top of the screen are pictures of bags of snacks. I pulled this from a CNN News report. They probably look like anything you'd see at a grocery store. The only difference is in the corner there, you see it contains THC. So even someone without the intentions of consuming a product that's drug laced could inadvertently consume if they don't look closely enough at the bag. There are the real manufacturers of the actual products that we're accustomed to are actually suing these organizations to try to get this stopped. And then beneath that, you see some pictures from social media that advertise some edible products. The drugs these days are very different than they were when I was younger, and they're much more potent and much more dangerous, and really much easier to hide. Thousands of young children consume them each year, whether purposefully or not, and they get sick. Nearly 1/4 are admitted to hospitals. Some even land in critical care from cannabis poisoning. So Again, just awareness is very important, and talking about it is very important. So let's talk about, I just want to finish up with some tips on maintaining your wellness by protecting your brain health. We talked earlier about that rotational chair and about how it was kind of a kooky little invention at the time, but maybe they were onto something. As it turns out, maintaining the health of your brain really does improve your mental wellness. Johns Hopkins neurologist Barry Gordon, he tells us that memory is just a tiny part of brain functioning, and there's a lot you can do to protect your brain health. And that a surprising amount of evidence actually points to aerobic exercise, so heart pumping exercise, as the number one thing you can do to improve your brain health. So we've always known it would help our hearts. It also helps your brains. They are not, researchers aren't sure exactly how it works. It might have something to do with the increased blood flow to the brain, strengthening connections between memory forming cells. It could be exercising triggers the release of certain brain chemicals that also help in those connections. So get exercise, aerobic exercise. Take care of your medical health. Chronic conditions, diabetes, heart disease, stroke, hypertension, they're all known to damage brain health. And the good news is that reducing your risk or better controlling these conditions can improve your brain health. Focus on your sleep, sleep well. There's increasing evidence that sleep disorders can cause problems with mental functionings, and two of the most common disruptors are sleep apnea and stress. I encourage you to review your medications with your providers. Some drugs can have effects on thinking, so review your medications. And finally, stay active intellectually and socially by doing exactly what you're doing here today. Stay engaged by taking classes, challenge your brain to learn new things, reading books, playing musical instruments, and so forth. So you guys are already making great choices, and I just encourage you to continue. So just wanted to finish by, really thanking you for your time and attention today, and seeing if you have any other questions.
We have a couple questions online.
Okay.
What is the difference between TMS and TDSC and electroshock therapy?
So one was like a low current, like a low voltage, low current direct electronic stimulation. One was magnetic.
How are referrals made to the new psychiatric ER? Do they take walk-ins? Is it EMS police, or are they those who first go to the regular ER?
So it's not open yet. It's going to be opening very, very soon. And when we do, we will accept walk-ins. We will also, just like any other medical ED, have an ambulance bay with special precautions for safety, keeping our patients, our potential patients safe. And as far as referrals go, if we have healthcare providers who want to put in a referral, if they're Riverside providers and they have the electronic medical record system, we use Epic, they can put a referral in there for that. So if there's a particular provider on the call who wants that information, I would be really happy to provide that as well.
And one last online question. Do you have any suggestions for finding a mental health provider in the days or these days where few providers are taking new clients?
That is a great question, right? Right, because they're overburdened. The needs are just that large. And sometimes what we have done to help our patients is if we discharge them with a plan to have a follow-up appointment in the community with an outpatient provider, and that appointment is not for, say, another month or so, what we've been able to do is set up bridge appointments for them in case their medications run out. We don't want them to run out and become critically unstable and back into care. We want them to stay as stable as possible until their follow-up appointment. So that's what we're doing. We know there's still more to do than that. We're working on it. We're constantly trying to think how we could evolve to meet the needs. So therefore, opening those mental health outpatient things, that program next, hopefully maybe later this month, at least next month, and then opening the ED to try to help provide more options, because we do know it's hard to get individual appointments. There is a long wait time for that. Yeah.
All right. Well, thank you so much for being here today.
Thank you, guys. Love meeting you, talking with you. Have a great afternoon.